Good evening, everybody. Welcome to Image Journal Club today. So today we are discussing an article which is on high-risk myeloma. We all know that high-risk myeloma is constitute around 20% of patients newly diagnosed multiple myeloma, and it is always a challenge to treat high-risk multiple myeloma. So Dr. Sarthak will discuss about the journal article, which is published in Blood couple of months back. And following the journal club presentation, we will discuss about the treatment of high-risk myeloma. So over to Dr. Sarthak.
Good evening. So I'll be sharing my slides. Is it visible?
Yes, sir, it is visible.
So today I'll be discussing a journal club on a paper which is published in Blood in the month of May this year, which is regarding use of a quadruplet, which is daratumumab, carfilzomib, lenalidomide, and dexamethasone, along with tandem transplant in newly diagnosed high-risk multiple myeloma patients. So as we know, high-risk cytogenetic abnormalities are associated with worse outcomes in patients with newly diagnosed multiple myeloma, and the current standard of care, which is daratumumab, in addition to a triplet, be it VTD, VRD, or KRD, it results in deep response rates and high MRD negativity rates in patients with high-risk newly diagnosed multiple myeloma. But the response rates as well as the PFS difference is not statistically significant and is not as well as in patients with non-high-risk multiple myeloma. So high-risk multiple myeloma, in all these trials, these patients are performing inferior as compared to non-high-risk multiple myelomas. So we do need risk-adapted strategies in high-risk multiple myeloma patients. And one of the strategies which has been used in some trials is a strategy of tandem transplant, which has resulted in PFS as well as OS improvement over a single transplant in newly diagnosed high-risk patients. So most of the initial pivotal studies which have led to approval of triplets as well as quadruplets have included less than 20% patients of high-risk multiple myeloma, except the Stamina study, in which, if we look overall, there is no PFS benefit with the tandem transplant. But if we take out high-risk patients in an extended 5-year follow-up, the PFS, the 5-year PFS is 43% in subgroup of patients which is receiving tandem transplants, and it is statistically significant. Similar results are also there in European Myeloma Network 02 study, which has showed that double tandem transplant has improved both 5-year PFS as well as 5-year overall survival in cytogenetic high-risk disease patients. So in this study, which I will be presenting, it is a multicentric single-arm open-label phase 2 study, which was conducted in 11 centers of IFM group from July 19 to March 2021. And in these studies, only patients who are having at least one high-risk cytogenetic abnormalities were taken among either deletion 17p, translocation 414, or translocation 1416. All these patients should be transplant eligible and with the age of less than 65 up, and a PS, performance status of ECOG 1 or ECOG 2, with an adequate renal function. Patients who were having grade 2 peripheral neuropathy or higher were excluded from this study. And a sample size of 50 patients was required to estimate a feasibility rate of the regimen of approximately 70% with a 95% confidence interval. So in this study, induction was given of a 20-day cycle. 6 cycles of induction were given of standard dose daratumumab, IV carfilzomib. The dose used was either 20 or 36 milligram per meter square on days 1, 2, 8, 9, and 15, 16, along with oral lenalidomide and oral dexamethasone. So 6 cycles of induction, 6 28-day cycles of induction were given in all the patients. And after induction, a stem cell harvest was done with chemomobilization with cyclophosphamide along with GCSF, and the target yield was taken as 5 million cells per kg. And patients who had a stem cell harvest with this yield were proceeded to go on autologous stem cell transplant, with melphalan being used as conditioning. After first autologous stem cell transplantation, 4 cycles of consolidation of DARA-KRD were given to these patients. The daratumumab was given in 2 doses per month. Carfilzomib was given here as 56 milligram per meter square on day 1, 8, and 15. Oral lenalidomide was used in lower doses, 15 milligrams, and oral dexamethasone was also used. After 4 cycles of consolidation, patients subsequently received second autologous transplantation with similar dose of melphalan being used. And after second autologous stem cell transplant, 2 years of maintenance therapy was given with lenalidomide and daratumumab. Daratumumab in maintenance was used 16 milligrams per kilograms every 2 months. So primary endpoint in this study, because this was a single arm phase 2 study, so primary endpoint was taken as proportion of patients who completed the second transplant, as this was taken as the primary endpoint. And secondary endpoint was taken as various response rates, MRD at each step of the program, quality of stem cell harvest, performance, progression-free survival, overall survival, as well as the safety analysis. So in this study, the median age of the population was 57. And most of the patients, 94% of the patients, were having a performance status of either 0 or 1. And the ISS scoring was 42% for stage 1, and 24% of the patients had stage 3 ISS in this study. And only 24% patients have RISS stage 3 in this study. 4 patients had presence of extramedullary disease at baseline, and 3 patients which were found to have primary plasma cell leukemia. So in every patient, there was presence of a high-risk cytogenetic abnormality. In 40% of the patients, deletion 17p was present. And in 52% of the patients, if you see, translocation 414 was present. In 50% of the patients, also gain of 1q was noted. So among all the patients, 60% of the patients had either 2 or more than 2 high-risk cytogenetic abnormalities. So out of all 50 patients which were started on induction, 4 patients discontinued during induction, 2 due to the regimen toxicity and 2 due to the disease progression. 4 patients did have a stem cell collection failure and did not receive transplant. So out of 50, -8, only 42 patients received first stem cell transplant. So there was no transplant related mortality in this study, and all of the 42 patients then went on to receive 4 cycles of DARA KRD consolidations. Out of these 42 patients, 2 patients further discontinued during the consolidation, 1 due to regimen related toxicity and 1 due to consent withdrawal. And 4 patients, when they were given stem cell mobilization with chemo mobilization, the stem cell collection failure was noted. So out of 42, only 36 patients went up to receive a second autologous stem cell transplant, and with second autologous stem cell transplant also, there was no transplant related mortality which was noted, and all the 36 patients were started on DARA-len maintenance. Now out of the 36 patients, 6 patients have completed the maintenance in this study, and in 24 patients the maintenance is still ongoing as per the study, and 6 patients discontinued during maintenance in this study, 1 and 5 due to disease progression. So with at least roughly 72% of the patients which were able to complete second transplant, if you note 36 out of 50. So this study met its primary endpoint of feasibility. And if we see the response rates, so by the end of induction, 95 overall response rate was 95% at the end of induction. 60% of the patients were in VGPR and 31% of the patients were in CR or more than CR. After consolidation, after a transplant, the CR or more than CR rate went up to 48%, and by the end of early consolidation, this CR rate went up to 70%, and before maintenance, this went up to 81%. So 81% of the patients were in CR before starting of maintenance in this study, which was 36%. So if we see the per protocol analysis, these are the response rates. If we see post second autologous stem cell transplant in 36 patients in per protocol analysis, roughly 80% patients did achieve either CR or more than CR rate. The MRD negativity rates, if we discuss, MRD in this study was done with NGS with the depth of 10⁻⁻5 as well as with the depth of 10⁻⁻6. So after induction, based on per protocol analysis, 53% of the patients were MRD negative if we go with 10⁻⁻5, and 43% of the patients were MRD negative if we go with a scale of 10⁻⁻6. And by the end of second transplant, that is before maintenance, per protocol MRD negativity rates were as high as 97%, which based on 10⁻⁵, and 94% if we see based on 10⁻⁻6. So but in the intent to treat population, which is the total population, the MRD negative rates were 64% with respect to 10⁻⁻5 and 62% with respect to 10⁻⁻6 before maintenance. So this is the MRD negativity rates which we can show which we can see on this figure. So post second transplant, if we see in per protocol analysis, MRD negativity rates were as high as 90%, 93% in this study. So survival, the median follow-up from the start of therapy in this study was only 33 months. And out of all of the 50 patients, 9 patients had disease progression. If we include those 2 patients also who discontinued, 1 patient who discontinued on due to stem cell collection failure and 1 patient due to adverse events. Apart from these 2 patients, 7 patients had pure disease progression. And among the 5 patients who had progression during maintenance, 4 patients achieved MRD before maintenance with the help of NGS. The median PFS and median OS were not reached in this study, and the 30-month PFS was 80% and 30-month overall survival was 91% in this study. And none of the parameters, whether which and how many high-risk cytogenetics are there, presence of extramedullary disease, and RISS score was significantly associated with either poorer PFS or response assessment in this study. So these are the curves showing the 30-month PFS being 80% and 30-month overall survival being 90% in overall per protocol analysis study. And if we see the stem cell collection failure, so initial 27 patients out of 50 patients had stem cell collection after 6 cycles of induction, with a median of yield stem cells of 6.1 million per kg. And after out of 27, because 6 patients, stem cell harvest was insufficient to proceed to tandem transplant. Therefore, after these 27 patients, the study protocol was further amended to collect stem cells after cycle 3 of induction. And out of those 21 patients after cycle 3, stem cell harvest was successful in 21 patients with a median stem cell yield of 8.3 million per kg. With respect to safety, 2 deaths were noted in this study, 1 due to septic shock due to infection in first induction, and 1 due to JC virus related progressive multifocal leukoencephalopathy during maintenance. And overall, 4 patients discontinued treatment permanently in this study due to regimen related toxicity, 2 during induction due to TLS and COVID-19, 1 during consolidation again due to COVID-19, and 1 during maintenance due to JC virus infection. Dose reduction in carfilzomib was also done in roughly half of the patients, and dose reduction in lenalidomide was also done in 3/4 of the patients in this study. So if you see the adverse events, the most common hematological adverse event was neutropenia, which was grade 3 neutropenia was noted in 32% of roughly 1/3 of the patients in induction, but the rates of neutropenia were much less in consolidation in this study. And the most common non-hematological adverse event was infection, which was noted in 42% of the patients during induction, but it was negligible when it was done on grade 3 and grade 4 analysis. Most of the infections were either grade 1 or grade 2 in this study. So what we can summarize is that in this population, DARA-KRD followed by transplant, autologous stem cell transplant is feasible in high-risk population who are fit for transplant. And this regimen, along with tandem transplant, results in high response rates and high MRD negativity rates. And this is relatively safe and well tolerated in their study population. But there were some limitations as the study sample size was very small. It was only 50 patients. No randomization was done. It was a single arm study. And because many patients who were MRD negative by NGS at the end of induction and at the end of consolidation were having progressive disease during maintenance. So this study needs longer follow-up. And another point which Sir will discuss is whether can the same results be extrapolated to our Indian populations, whether these regimens can be tolerated in the Indian population. Thank you.
Okay. Speaker. Thank you. Speaker. Yes. Thank you, Dr. Sarthak, for the nice overview of this phase 2 trial. So this is a feasibility trial. Feasibility means that they wanted to see whether this much of intensive chemotherapy, how many patients can tolerate. So this is obviously a Western population. The trial was done in France, and it is a phase 2. And the group in France is IFM, which conducts all these studies about the transplant. The first study about the transplant, auto transplant, which became standard of treatment, came from IFM group, and I think the article was published in New England Journal of Medicine in 1998. So high risk myeloma is always, is a problem. So that's why, people keep on doing the trial. How can we improve the outcome of these patients? Let me share some slides which I have made on the high risk myeloma. Okay, so if you look at the trials in high-risk multiple myeloma, we have a master trial where DARA-KRD was given for 12 cycles with a single transplant, and somebody who achieved an MRD negativity, 2-year PFS was 84%. So in this phase 2, the PFS is close to 90% or so. Another trial, the GMMG concept trial, where isatuximab with KRD was used for 3 years. Transplant, and the 2-year PFS was 78%. So this is all trials in high risk population. Then optimum trial where DARA CVRD, so 5-drug combination, cyclophosphamide was added to the VRD regimen and the DARA VRD regimen, followed by transplant, followed by DARA VR consolidation, followed by DARA DR maintenance. The 2-year PFS was 81% or so. So the questions which are there in the high-risk multiple myeloma is, how many drugs do you require? Do you require 3 drugs, 4 drugs, or 5 drugs combination? So currently the standard is to use 4-drug combination if the patient can afford. The second question is, what should be the duration of induction therapy? Obviously, we do suggest doing a transplant in all these patients. So hence, if your induction therapy is prolonged more than 6 cycles or so, then you can face a challenge in the stem cell collection. So preferably, the transplant should be done after 4 to 6 cycles of induction therapy in these patients. Then the question is, how many transplant, whether you require a single transplant or a double transplant. In the STAMINA trial, which Dr. Sarthak discussed about in his journal club presentation, there, even though the consolidation did not benefit the patients, but patients who had a partial benefit with an autologous transplant, they did benefit with a second transplant. Another question is, if you are doing a double transplant, whether it should be a kind of a tandem transplant, which means that as soon as the patients recover hematologically, you go for a second high-dose chemotherapy in a transplant, or you give a gap of 3 to 6 months to let the patient recover and then do the second transplant. But in this phase 2 trial, which Dr. Sarthak discussed, they faced a problem in the stem cell collection. So that can be a challenge if you are putting a gap between the first transplant and the second transplant. And then the next question is, what should be the maintenance therapy? And currently, all high-risk patients should receive 2-drug combination as a maintenance therapy. The problem is whether these 2 drugs can be a combination of bortezomib lenalidomide or bortezomib daratumumab or lenalidomide with daratumumab. So obviously, in Indian setting, we prefer to use bortezomib and lenalidomide as combination rather than DARA with len or DARA with bortezomib. And the next question is, what should be the duration of maintenance? And again, the current consensus is in all high-risk multiple myeloma patient, it should be indefinite unless the patient is not able to tolerate. And then you do an MRD, bone marrow MRD should be negative and the image should be negative before you consider stopping the therapy. So the next question is, when you define the high-risk myeloma, is it only the cytogenetic based? That means, like in this journal, they defined as deletion 17p, P414 and 1416. And again, sometimes you need to know the percentage of these cytogenic abnormalities. In this journal, they took at least the patient should have 30% of these abnormalities before they say, yes, definitely this patient has 17p, 414 or 1416. The next is whether there should be even a single high-risk cytogenic abnormality is sufficient, or it should be two or more than two. If there are two, then generally we call it as a double hit. If there are three, then we call it as a triple hit. And along with that, 1q and 1q amplification does matter along with these abnormalities. Besides that, we also know that even if this patient does not have these cytogenic abnormalities, patient has an extramedullary disease or plasma cell leukemia, they would put the patient into a high risk category. So in this journal, the 4 patients had plasma cell leukemia. And one of the positive feedback from this journal is that if you give this kind of a regimen, you don't need to give chemotherapy for plasma cell leukemia. You can just give a 4-drug combination of and double transplant, and you can have a reasonably good follow-up. And the last thing is that even if we have seen that sometimes, the patient do not have these cytogenetic abnormalities, the high-risk cytogenetic abnormalities, they do not have extramedullary disease, they do not have plasma cell leukemia. But even then, some of these patients behave poorly, what we consider as standard risk, but they never go into remission and they relapse very early. So this is what we call as functional high risk, meaning thereby that we are still, not that much advanced that we can define all the patients as high risk, even when the cytogenic abnormalities are less. In the future, obviously, all these high risk patients are going to get either BiTE therapy or a CAR T cell therapy. And then the question would be, how do you sequence the drugs? Whether these patients, would you do an autologous transplant followed by a CAR T or a CAR T? Which type of CAR T, whether it should be a BCMA or GPCR5 CAR T. So those are the questions which obviously the future transplant, future research trials will help. And finally, it would come down to patient-tailored approach in this patient. So in this study, IFM 201804 study, this is what they have said, boot kind of a thing. They have shown that the induction therapy, 6 cycles of induction therapy, then a transplant, which is a big boot, then consolidation, the same therapy repeated as consolidation, followed by a second transplant, and then followed by a 2 drug maintenance. So which boot will fit the treatment of patient? That is a challenge in this in all these high risk myeloma patients. And this trial actually adds to the information that if you first is the feasibility, that means the patient can tolerate, and the second obviously is that if the patient can tolerate, you can do this much of intensive chemotherapy in these patients. The last question obviously is whether Indian patients or the patients in the developing countries can tolerate this much of chemotherapy or not. That is obviously a challenge, because we know the risk of infections in our patients is close to more than 50%, and at least the infection related mortality is 15 to 20% in myeloma patients. So those, and plus the tolerability of the drugs, would also be a challenge in our patients. With that, I thank you very much and invite questions from the audience. And I think there are some questions from the audience. Are there any questions from the audience? And I open the house for discussion. Dr. Bhausab.
Yeah, thank you, sir, for the nice overview, sir. Sir, so you mentioned all the 4 studies in the 3 studies specifically in the high risk myelomas, the Optimum, GMMG concept, and IFM. And sir, looking at Optimum, it uses only Optimum and concept. They use only one transplant, and outcome, however, looks similar to the IFM study. So how much credit, sir, do you give to tandem transplant in this quadruplet age, and do you recommend or practice, sir?
So I think the problem is when we compare the cross trial, start doing the cross trial comparison, because the number of high risk cytogenic abnormalities, the percentage of patients may be different in the different trials. Here, 40% of patients had 17p as the 40% patient had 17p as the high risk cytogenetic abnormalities. So we really, when we are comparing one trial or the other, it is very difficult unless, it is a kind of a randomized trial. Only then we can say how much transplant is contributing, one transplant or two transplants are contributing. From the available knowledge, we know that patients who do not respond very well to the first transplant, meaning thereby they have not achieved an MRD negative status, definitely they are the population who would benefit with the second transplant. That we have knowledge about that. But if the patient has achieved an MRD negative status after the first transplant, whether a second transplant will contribute something in these patients or not, that is a difficult question to answer unless we do a randomized kind of a trial. And again, when we are looking at the MRD negative status, we also need to know whether we are doing 10 raised to power -4, -5, -6, and whether we are doing by next generation sequencing or we are doing by flow or by any other method. So all these questions will come. So it is very difficult to compare one trial with the other trial. I hope that answers your question.
Yes, sir. I think very interesting point and very valid point of not comparing the trial. But only thing which I wanted to, which struck to me was Optimum used high risk definition as patient with two high risk abnormalities or the gene expression signature or plasma cell leukemia. And also the GMMG concept also required ISS 2-3 with the additional. While this study had a slightly lenient definition of high risk, and despite that, the result looked comparable to me. So that's why I asked the question. But I get your points are very, very valid, and the practical tip of using the response to first transplant to decide on second is also very good, sir. Thank you, sir.
Thank you. Sumit?
Hello, sir. Am I audible?
Yes, yes.
Something which was unique was 16% out of these 50, which means 8 patients did not mobilize enough stem cells. And all of them had underwent actually a chemo mobilization, which is otherwise a good mobilization. So I wanted to ask this to Sarthak as to in the first 6 cycles, after the 6 cycles, when they did it, 25% did not collect stem cells. When they did after 3 cycles, 10% or roughly 8% did not collect stem cells. So did they always collected for both the transplant in the first instance, or for the second transplant they collected the stem cells again during the DARA KRD consolidation?
So so they initially in the trial protocol they mentioned that after 6 cycles they would do these chemotherapy mobilization and stem cell collection, but then they faced failure, so then they made it after 3 cycles of induction chemotherapy. Now the interesting thing is they did not use plerixafor. Now plerixafor, we here whenever we are using DARA VRD kind of a regimen, I think quite a good number of patients of ours, we have to use plerixafor as the mobilizing agent. And we have published also that when you are using DARA, there is always a problem in mobilization. So they, as a part of protocol, use cyclophosphamide, and they did not use plerixafor. So I think if they have used plerixafor, this is a postulation, that probably they would not have faced this kind of a problem in getting the stem cell yield, especially after 3 cycles.
Agree, sir. And have they mentioned that they collected again for those who are going to do the second transplant during the consolidation, or they were going to attempt all the collection at once in the first collection only?
In the first collection, I think in the first collection only. Sarthak has some problem in connecting, so that's why I'm answering on his behalf.
Okay, sir.
Achha, so okay. First collection. Okay, Sarthak says that from the first collection only they collected for the 2 transplants.
Okay, sir.
Yes, Arun.
So my question was actually, sir, with respect to the entire regimen, like you showed that beautiful graph wherein there were small boats coming in tandem and there is a big boat of transplant. What my query was this, like with a quadruplet induction, which has anti-CD38 and a higher generation proteasome inhibitor, with a quadruplet consolidation and a doublet maintenance with DARA and LEN. I don't know how much is tandem transplant actually helping the patient. Actually, that is what I believe. And like what you said with the bikes and CAR-T coming up, I think maybe it will be more easy to once you have access to all these drugs. I think maybe the tandem transplant maybe slowly lose out on the charm it has, because with such kind of intense regimen at induction, consolidation, and a doublet maintenance, it's very difficult to singularly tease out that tandem transplant actually would benefit the patient in the high risk. It's actually a mixed cocktail, I think, which has helped this patient tide over the high risk for some time. So, what your opinion on that, sir?
Yeah, so in one way you are right that how much second transplant has contributed. But if you look at their results, so the MRD negativity rate had gone up after the second transplant before they put the patient on maintenance therapy. So at least you can say that MRD negative rate, if you look at the per protocol, almost 94% of patients have achieved an MRD negative status, which is very, very high and unheard of in the high risk population. So in that sense, definitely the second transplant has added. How much it will benefit for the future, we really do not know, because high risk population is always a bad kind of a myeloma. So that is the reason, when people are making these very intensive kind of a protocol in these patients. But we also know that phase 2, your results are always better, and unless you check these results in phase 3 by doing a randomization, only then you can come to the conclusion. So it is possible that if they do a phase 3, then second transplant may not benefit. And my personal opinion is that it is unlikely that in future we are going to do these kind of trials, because of upcoming CAR T cell therapy and the BiTE therapy. So they are going, I mean, the next trials are going to incorporate these kind of therapies in these patients.
Thank you, sir. Thank you, sir. Sir, just one more point, if I could, sir, if you could permit, sir.
Yeah.
Yeah. So this was regarding this total therapy concept. Like now we have data followed up for almost 20-25 years that Barlogi, the group which actually started with this total therapy, they actually revolutionized the tandem transplant. They also did a tandem transplant. They followed a patient for fairly long period. But from that era to this era or this trial, what I find different, what this group did actually was, I think, the anti-CD38 axis, the carfilzomib axis, which probably at that time was mostly thalidomide and cyclophosphamide and maybe bortezomib in some of the groups. So I was just wondering, like over the last 2 decades, tandem transplant has always been there, but what probably changed was the supportive care, which may make an impact in the survival outcomes. And definitely for deepening of MRD, we have now the anti-CD38 and the higher generation proteasome inhibitors, which are now available, which are probably not available to that group. Tandem transplant was probably available even then, but I think nowadays I think we have access to these drugs also. So maybe that also helps to deepen the MRDs and sustain them for long periods and maybe give even survival benefits.
Yes. So the concept of total therapy was that if you can achieve curability in some patients, and even these trials also is kind of a total therapy where you are combining the proteasome inhibitors with the immunomodulator with the antibody based therapy and high dose chemotherapy. So you are trying to use all those options which are available. So but again, even then even in this 50 patient, a small series, we know that even during the induction therapy, there was progression in 2 patients during induction. So you can imagine that even with such high dose intensive chemotherapy, even then, high risk myeloma patients will progress. So that is a challenge. And again, our understanding is still not complete in understanding the high risk myeloma patients.
Thank you, sir.
So are there any questions from the audience?
No, sir, not yet.
Dr. Hari, you are there. Anything you want to say?
No, I just thanks, Pankaj. That was a wonderful discussion. I just feel that probably what we need to draw conclusions over here is: does tandem transplant have a role to play in the era of using of daratumumab? What has got the added benefit? And that is something that we can mull over a little bit. There is a signal that probably there may be a benefit for some high risk groups achieving higher MRD negative status. And from that, I would only draw conclusions from that perspective. What we have in the backbone of using a daratumumab based regimen for a tandem transplant over here. That's what I would think.
You are absolutely right. So that is what even Sumit also mentioned the same thing. Dr. Tapan has joined, sir. I think in your practice you must have done some tandem transplant. So, what is your opinion?
No, not really. So I just wanted to know what happened to those plasma cell leukemia patients in this cohorts of patients.
So out of 4 patients of plasma cell leukemia, 3 were in MRD negative status. 1 patient progressed.
Okay, they're still in MRD negative status.
Yes.
Yes. That's nice to know.
Yeah, that is one positive thing, that instead of giving chemotherapy to these patients, so if we give this form of therapy, probably you can tackle some plasma cell leukemia.
And Pankaj, another thing, that 30% cutoff. So someone with a 5% 17p and someone with a 75% 17p, they are 2 different patients?
Yes, sir.
Biologically?
Yes. So although the US people feel that whatever positivity is there, all are high risk. In the Europe, these people believe that no, we have to have some percentage, 20% or 30% of TP53 before we say that these are high risk. And the reason is, in our practice also we have seen, even if there is TP53, but some patients behave very aggressively and some patients do very well. So there is a controversy, not a controversy, there is not a full consensus on the positivity, cutoff for positivity of high risk TP53 percentage.
Okay, yeah, thank you.
Thank you, sir. Uday, you have any comment?
So there is one question in the chat box. Someone has asked.
So the question is hypogammaglobulinemia induced by 4-drug regimen, role of IVI. I think they have not looked at hypogammaglobulinemia, but yes, the risk would definitely be high. And the current consensus is any patient who is having recurrent infections, then you have to supplement IVIG in these patients. Uday, you have any comment?
No, sir. No comments, sir.
So just on that, I just had to one observation in the 2 patients that we have done transplants in the background of having used daratumumab as an induction therapy. Yes, we are encountering a significant amount of sort of post-transplant related recurrent infections, and their IVI immunoglobulin levels are low. And I have been many a time contemplating whether I should give them some IVIG over here, because the infection, the amount of infections that are happening in these patients in the background of daratumumab-based conditioning followed by transplant is probably a little bit more, but that's just an observation.
Right. Thank you. Thank you. So if there are no questions, I think we had good discussion about this journal, and now I can hand over to Dr. Sumit Mehta for the Eagle Eye competition.
Okay, sir. Just 1 minute. Is my screen visible?
Yes, sir, it is visible.
Okay. So for this month, that is July 2024, we had chosen this article, that is pomalidomide, bortezomib, and dexamethasone for newly diagnosed multiple myeloma with renal impairment, a Chinese study, but very relevant to our country. So the process of the Eagle Eye competition is, I will just go ahead and an overview. We select a recently published article of plasma cell dyscrasias. We invite anybody with an interest in plasma cell dyscrasia to send a commentary of 175 words before due date to us. And the best commentary is selected by a team of blinded reviewers. Whosoever wins gets to present this in the presence of an international and national audience, and along with that, get some vouchers, which is important. The intent is to read the latest articles of plasma cell dyscrasias, know the art of critical appraisal, refine the art of scanning an article, writing more letter to editors from India, and get an opportunity to present in front of a very good audience. This will also generate some inter-institutional competition. So there are multiple variables on which the commentary is analyzed: the summary, the title, the abstract representation, author's core assumptions, critical word count and word limit, errors in the author's interpretation and facts, some ideas which may be over or underemphasized, approaches and research methods, statistical methods, and culminating all of this, we reach a final score. Most important things are the person who's writing the commentary has to stick to the word limit. Being succinct and still convey your critical analysis in lesser amount of words is also important. And we always encourage students to concentrate on methodology and statistics. So the winner of commentary for this month is Dr. Deep Gala. He's a senior resident from pursuing DM in clinical hematology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. So hearty congratulations to Dr. Deep Gala. And I would request now Priyanshi to share the recorded video which has been shared by Deep of this article.
Good evening, respected teachers, mentors, and dear colleagues. I would like to thank Image Group for this wonderful opportunity. Beginning with today's journal scan, topic for today's discussion is pomalidomide, bortezomib, and dexamethasone for newly diagnosed multiple myeloma patients with renal impairment. This is a research letter published in Blood Advances on 15th of December 2023. Coming to the introduction, 20 to 40% patients with multiple myeloma will have renal impairment at diagnosis. Renal failure is the second leading cause of death in newly diagnosed patients with multiple myeloma. Renal impairment poses an increased risk of early mortality and significantly shortened survival. Bortezomib-based triplet regimens, including cyclophosphamide, doxorubicin, or thalidomide with dexamethasone, are currently recommended for patients with multiple myeloma and renal impairment as per IMWG. Lenalidomide requires dose reduction in patients with renal impairment, while pomalidomide is effective in cases with renal impairment and does not require dose reduction. Coming to the mechanisms of renal injury in patients with multiple myeloma, the main precipitating factor is the free light chain. The free light chains can affect any part of the nephron from proximal to the distal tubule. However, formation of cast in the distal tubule is subsequent tubular interstitial injury is the most common cause of severe acute kidney injury in patients with multiple myeloma. Apart from this, there are a host of other factors like hypercalcemia, drugs, dehydration, infection, which can precipitate renal injury in patients with multiple myeloma. Coming back to the current study aims to evaluate renal responses with pomalidomide, bortezomib, dexamethasone in newly diagnosed patients with renal impairment. The primary endpoint of the study was 3-month renal overall response rates, which included minor renal response, partial renal response, plus complete renal response. Renal responses were defined as per the current IMWG criteria. A minor response was if the baseline GFR was less than 15, then it should become 15 to 29 ml per minute. Or if the baseline GFR was 15 to 29 ml per minute, then it should increase to 30 to 59 ml per minute. A partial renal response was defined if the baseline GFR of less than 15 ml per minute becomes 30 to 59 ml per minute. And a complete renal response is defined if the baseline GFR was less than 50 ml per minute, then it should become more than 60 ml per minute. This was an open label phase 2 multicentric study conducted at 29 centers across China. The study group included newly diagnosed patients with multiple myeloma aged 18 to 80 years with renal impairment, which is defined as eGFR of less than 40 ml per minute using the MDRD equation. The renal impairment in the study was limited to patients with cast nephropathy, which was confirmed using a biopsy or a clinical judgment was made for the same. Diagnosis and response assessment of multiple myeloma was done as per the ideology criteria. The PVD therapy was given for 9 cycles. During the first 2 cycles, it was of 21 days with pomalidomide on days 1 to 14 and bortezomib on day 1, day 4, day 8, and day 11, and dexamethasone on day 1, 2, 4, 5, 8, 9, and 11 and 12. After the first 2 cycles, it was shifted to 35-day cycles with weekly bortezomib and 21-day pomalidomide. A total of 61 patients were recruited. Median age of the cohort was 61 years. 56.9% had RISS stage 3 disease. Majority of the patients had light chain multiple myeloma. Median EGFR of the cohort was 13.87 ml per minute. 19.7% patients required dialysis at the time of residency. At 3 months, renal overall response rate was 75.4%. 36% patient had a minor response, 10% had a partial response, 29% had a complete renal response, while 25% patients did not have any renal response. The renal response rates further improved to 78.7%. Median time to achieve this response was 21 days. 8 of the 12 dialysis dependent patients became independent at the median of 26 days. Early rapid reduction of the free light chain was significantly associated with a 3-month overall renal response. At 3 months, the hematological overall response rate was 86.9%, of which 63.9% had a VGPR, while 24.6% had a CR or above. Only factor which was significantly associated with renal response was a 82% reduction in the free light chain at day 22. This significance was established using multivariate analysis using the logistic regression, for which sample size was adequate. Coming to PFS and OS, the median follow-up of the study was 16 months. Three patients had progressive disease while 4 patients expired. The main cause of death was thrombosis in 2 patients, pneumonia in 1, and myeloma progression in 1. 18-month PFS and OS was 90.6 and 91.7% respectively. There was a significant difference in the overall survival when it was factored as per the renal response. The 18-month OS for patients with renal response versus patients with no renal response was 97.9% versus 56.4% respectively. The Kaplan-Meier curve shows early separation and then it becomes parallel, suggesting like there was likely early mortality associated with those who do not achieve a renal response, and once the renal function stabilizes, survival becomes similar between the two groups. However, longer follow-up is required to confirm such a conclusion. The most common adverse events observed with PVD were infection, peripheral neuritis, myelosuppression, rash, thrombosis. 2 patients expired due to thrombotic event. Comparing the current study with the Indian data, a similar study published by PGI Chandigarh in 2022 had 91 patients with newly diagnosed multiple myeloma with renal involvement, of which 69% had a cast nephropathy. The therapy used in that study was bortezomib, dexamethasone, along with cyclophosphamide, thalidomide, or lenalidomide. Pomalidomide was not included. Median age of the patient was 60 years. Renal response rate was similar in both the studies, 73% in the study by PGI Chandigarh, whereas 75.4% in the current study. The dialysis independency rates were 55%. In the current study, they are 66.7%. The current study has a higher hematologic response rate owing to the use of pomalidomide upfront. So to summarize, the current study has following strengths. That it is a prospective multicentric trial. It is the first study to evaluate renal response with PVD in newly diagnosed patients of multiple myeloma with renal impairment. It demonstrates high rates of renal response. There are high rates of dialysis independency with this therapy. There is significantly better survival for those who achieve renal response. But study is not out of its limitations, that it is an open label phase 2 study. There's a small sized cohort. Only patients with cast nephropathy were included. There's a shorter follow-up duration. ROC analysis could have been performed to determine the eGFR value predicting the renal response. Given all the strengths and limitations, the study remains relevant in Indian perspective, given the high burden of the disease in our country and availability of generic pomalidomide, which could reduce the financial burden. RCT comparing VPD with other bortezomib-based regimens for myeloma patients with renal impairment is desirable and feasible at consortium level. Thank you.
Thank you, Dr. Deep, for such a nice presentation. I'll just share my slides once again. Congratulations, Dr. Deep, once again. So, in order to give enough time to our students and those who are interested in plasma cell dyscrasias, we are announcing the article for Journal Scan for the next month, that is August 2024. The theme for the next month is on plasmacytomas. This is a original article published in American Journal of Hematology in 2020. It's real-world data on incidence, clinical characteristics, and outcome of patients with macrofocal multiple myeloma in the era of novel therapies. This is a study from the group of Greece and Israel, a collaborative myeloma working group. This is a freely available article from the American Journal of Hematology. I'll just keep this slide on for the next few seconds. Whosoever is interested can write a commentary on this article of 175 words and mail it to us. The subsequent mails will be circulated in the next few days. Thank you. Over to Dr. Arun.
Thank you, Dr. Sumit. I'll just share my screen. Dr. Sumit, is my slide visible? The screenshot mode, and am I audible?
Yes.
Yeah, thank you. So without much ado, let me just take you through the quiz which we do every session. And as a prelude, we know we start with one trivia and move on to the question based on the journal club and the journal watch we just discussed. So the first question, this is a trivia for you. So these, in fact, is the group of researchers who actually pioneered tandem transplant way back in 90s. And I would, these two people, I would say, have been very instrumental in evolving this concept. And these, the group actually came up with the concept of curing myeloma. So if A is Dr. Bart Baloji, who is B, and you have 4 options to choose from. You can see the BJH paper here. This was actually a seminal paper in the British Journal of Hematology in way back 2006. The group which actually colluded together have departed, but I would say even 20 years down the line, they have been publishing their results as late as November of 2023. My next 2 questions would be based on the beautiful journal club topic that was discussed by Dr. Sarthak on the tandem transplant and heavy arm induction and consolidation. So you have to choose the incorrect statement with respect to the design of the study. A lot of it has been discussed threadbare by Pankaj sir, so it can make things easy for you. I move to the 3rd question. This is an important question, I think, and this, I think, was also discussed threadbare. So in the phase 2 trial by IFM, what was the main cause of treatment discontinuation before the second transplant? You have 4 options flashed here. Was it the adverse events, disease progression, insufficient stem cell collection for a tandem transplant, or concerned withdrawal, which sometimes happens with these intense regimens? The next 2 questions was on another beautiful study highlighted in the journal Scan, that was about the newly diagnosed myeloma with acute kidney injury and pomalidomide bortezomib dexa regimen. So with respect to the design, you need to identify which is the incorrect statement. If you have been careful with the study protocol, I think, and it's a doable study in our setting, so you have to choose the incorrect option. And that brings me to the last question, which again based on myeloma-caused nephropathy, a term we sometimes loosely attached. So with respect to myeloma-related renal impairment, which is an incorrect statement? So you have to choose the incorrect statement, or you can choose whether all these statements are correct. Thank you. While the organizers compile the results, I'll just take you through the answers. So this is Dr. Baloji and this is Dr. Seema Singhal. She did her graduation from the SAGS and then post-graduation from KEM, and then she just took the world by storm, I would say. And she's one of the pioneers in myeloma management and actually pioneered the concept of the tandem transplant and was part of this group to actually introduce the concept of functional cure through total therapy. Regarding the tandem transplant trial by the IFM group, 1Q amplification was not considered by this group as a part of high risk in their study criteria. We now know 1Q amplification would now qualify as a functionally high risk group. This has been discussed. This is some, like when you put so much of intense therapy way up front, you do a quadruplet induction followed by a melphalan, then consolidate with 4 drugs again, you would definitely may not have adequate stem cell reserve for a tandem transplant. And 8 out of 50 is a sizable number, even in this phase 2 study, who didn't actually undergo the second transplant. This is an important thing which if you have noticed carefully, the form dose is for 14 days and not 21 days. And they use the full dose of pomalidomide because pomalidomide doesn't need any dose correction, but it is 14 instead of 21 days. All other statements were correct. This is about myeloma-related renal impairment. And if you see the current figures, close to 20 to 40% of patients with myeloma actually present with renal impairment. That depends upon what criteria you use to define renal impairment, whether it is an EGFR or a creatinine or a biopsy. And 2 to 4% would require replacement. If you actually could avoid renal biopsy in somebody who tends to have a free light chain levels more than 1500, but if you have non-selective proteinuria or when the involved serum free light chain is less than 500, you better biopsy that patient rather than wrongly label them as calf nephropathy. And so all of these are correct statements. This is a beautiful paper which has come up, which has been published by the International Myeloma Working Group. I would request all the AVID myeloma experts, panelists, and even the AVID listeners here to go through this beautiful recommendations which are like way out. And this is a beautiful group who have summed it up for us. With that, thank you all for a patient hearing. I would request.
While the results are getting presented, I would just add about Seema Singhal. So Seema Singhal is wife of Dr. Jayesh Mehta, who is son of Dr. B.K. Mehta or Dr. Mehta, who was in Mumbai, a hematologist.
Dr.
BC Mehta, BC Mehta, BC.
BC Mehta, yes. So Dr. Tapan would know about that. So Dr. Seema Singhal is more known for the first paper on thalidomide use in multiple myeloma, which was published in New England Journal of Medicine in 1999. And I can just share a story. So she was working with Dr. Badlogi in the Arkansas, at the myeloma, the only myeloma center, I think, in the world, only dedicated to myeloma. And so the story about thalidomide is that Judah Folkman was working on these drugs, which are immunomodulatory drugs, and wife of a cardiologist who actually had multiple myeloma, and there was no more option for him for the treatment of myeloma. So she approached Judah Folkman that is there any drug which we can give? You know, it is the last stage now, we cannot do much. So he said, okay, you can try this drug, thalidomide, which is, we all know that used for the lepra reaction because it was banned in 1962 or 63. So she actually tried thalidomide, got the drug, and it is only manufactured in Germany at that time. Even in India also, the drugs, the patients with the leprosy in Chennai was getting this drug from Germany only, free of cost. And that drug did not benefit her husband. But then there was another patient who got this thalidomide and benefited from him. And then they planned to do a trial at the Dr. Badlogi Center. And in one of the talk, which I happened to listen, where Seema Singhal shared her experience. So she said that she given a thalidomide and then she was on holidays. She came back to India. And at that time, the net connection was not very good, but so the patient was sending her emails about the M-band quantification every week, but she did not get time, or she did not have a good connection of internet in India. So when she went back from the holidays back to USA in the month of January, and then she checked all the emails, and then she could see that the M band is going progressively down. And then she shared this news with Bart Badlogi, who, was so elated, and he opened up the window and said, we have found a new drug for multiple myeloma after so many years. And this is how, we had the thalidomide. And then, obviously the immunomodulator drugs, lenalidomide and pomalidomide, which became the one of the major backbone of treatment of multiple myeloma. Dr. Tapan Sekia, sir, if you want to add something to this, this is the information which I had, but if you have something more.
Yeah, you are correct. You are correct. As it goes on any story, there are many versions of the story. I will not open up that part of it. Whatever you said, let it be, let it be there. Okay, all right. Both Seema and Jayas are very dear friends. Okay,
Right,
yeah,
sir.
okay, right.
So over back to us for disclosing the.
So we have our winner.
Yeah, Priyanshi, you could announce, yeah.
Yeah, Mr. Deep Ajay Gala. He's from SGPGIMS, Lucknow.
Yeah, I think he's the same Eagle Eye winner as well. I think we have a doublet. Dr. Sumit did this feat, I think 6-9 months ago. He actually championed the Eagle Eye competition with a beautiful journal scan somebody posted, and then he won the quiz the same time. So I think it's the second time it's happening in last 2.5 years we have been doing and meeting of this. So it's congratulations, Dr. Deep, for your achievement. Please stay tuned to us, and please do following the group. Thanks. Thank you. And congratulations. What await you is a voucher and a certificate. We'll be sending it across to you. So your bags are full. With that, I would hand over the proceedings back to Dr. Sumit.
Over to Dr. Pankaj sir for concluding remarks.
So we had, I think, a very good discussion about the journal article, the phase 2 study, followed by the journal scan. And congratulations again to Dr. Deep for both for the journal scan as well as for winning the quiz. So, and thank you everybody who has joined this webinar. And as Dr. Sumit said, the next webinar is going to be on the 4th Thursday. That means 22nd of August. And we will share the article as well as the faculty who would be supervising that in due course of time. So keep yourself tuned. And I thank all the faculty who has joined, Dr. Tapan Sekia, Dr. Hari, Dr. Uday, Sumit, and Arun, as well as the Mice Ideas for holding this webinar going smoothly. With that, thank you very much, and see you next time.